Welcome back. In the last lecture, we have discussed the different stages of impaired host defense. In addition, specific infections in relation to these stages were described. The phase of intense immune suppression and risk factors were discussed, and one of the most important infections in transplant patients, namely CMV, was explained. So, how can we apply this knowledge when we study other important viral infections in transplant recipients, like BK virus or EBV? In this lecture, we will learn about risk factors, stages, monitoring strategies, and therapeutic options for BK and Epstein-Barr virus infections. So, let's start with BK virus. This polyoma virus is, just like CMV, highly prevalent in the general population. Like CMV, there are many subtypes further divided into subgroups. Primary infection with BK virus typically occurs during childhood. The virus remains latent in the kidney and B-cell lymphocytes forever thereafter. Similar to CMV, BK virus is transmitted by the latently infected kidney from a seropositive donor. As with CMV, a seronegative recipient carries the highest risk of developing BK virus-associated nephropathy as a result of primary infection. This is followed by an infection in a seropositive recipient from a seropositive donor, called superinfection. Almost invariably, tubular epithelial cells will be affected by some degree of BK virus replication, which will reach an equilibrium after 10 weeks. About 40% of patients become BK virus positive in their urine during the first 3 months after transplantation. If there is insufficient recruitment of BK virus-specific cytotoxic T cells, the continuing BK virus replication will lead to protected tubular epithelial damage, with increasing inflammation and injury, resulting in what is called polyoma virus-associated nephropathy, or PAVN. PAVN is invariably preceded by BK viremia. Most cases that occur within the first year of transplantation are associated with pronounced immunosuppression and can lead up to 50% of graft loss. Therefore, guidelines advise monthly screening for viremia for the first 3 to 6 months and then every 3 months during the first year. Any unexplained decline in renal function should prompt PCR testing of blood for BK virus. As there is currently no effective antiviral therapy, prompt lowering of immunosuppression, especially of anti-metabolites such as mycophenolate mofetil, is the only strategy to enable viral clearance and prevent further progression to PAVN. The third infection, EBV, is different from CMV and BK virus infections in that it can cause malignant transformation of B cells, called post-transplantation lymphoproliferative disease or PTLD. Primary infection with EBV results in a lifelong latency of the virus in memory B cells. Reactivation may occur when memory cells differentiate into plasma cells. The resultant transient viral replication leads to cell lysis. In a normal host, this is controlled by re-establishing latency through differentiation into memory B cells and by the cytotoxic T cell responses to all other B cell stages, which are expressing EBV antigens. In case of severely impaired immune response, uncontrolled viral replication may lead to infection of germinal B cell stages. These stages are at higher risk of transforming mutations, resulting in the development of oligoclonal or monoclonal malignant B cell populations. Primary infection is a major risk factor for developing PTLD in the first year after transplantation. CMV disease is another important risk factor, as is the repeated use of anti-lymphocytic antibodies for induction of or treatment of acute rejection, as explained in Module 3. The clinical spectrum of the disease is highly variable, ranging from self-limiting infection to overt lymphoma. The gold standard for the diagnosis of PTLD is pathological examination. High viral loads of EBV are predictive of PTLD if accompanied by low-level cytotoxic T cell responses. If reduction of immunosuppressive therapy is unsuccessful, treatment with anti-CD20 antibodies is the next option. Clearance of EBV load is usually associated with clinical responses after treatment. In this lecture we discussed BK and Epstein-Barr virus infections. There are still many other important infections which might compromise the patient after renal transplantation. Since it's impossible to discuss all of them, we have added additional literature and assignments, so there's a chance to extend your knowledge. Which infections are mostly seen in transplant patients in your country? Submit it to the forum and discuss it with your peers. So what have we learned in this second part of this lecture? During the phase of intense immunosuppression, the immune control of chronic viral infections weakens. This may lead to new infections or reactivation of viruses present in the donor kidney or in the organ recipient. Besides CMV, BK and Epstein-Barr virus are important infections in the transplant recipients. If there's insufficient recruitment of BK virus-specific cytotoxic T cells, continuing BK virus replication will lead to protected tubular epithelial damage. This leads to increasing inflammation and injury, resulting in what is called polyoma virus-associated nephropathy. The clinical spectrum of EBV disease is highly variable, ranging from self-limited infection to overt non-Hodgkin lymphoma. In the next lecture, we will discuss another important downside of immunosuppression, namely malignancies. Of interest, many malignancies are related to infections, as you've already heard in this lecture. But until then, I look forward to your contribution on the forum.